Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarnet serves as the event hosted by Indian College of Anesthesiologists, and the focus of today's session is Superspeciality in Anesthesia and Future Avenues. Now, I would like to invite Dr. Vimla Sharma ma'am to proceed. Over to you, ma'am. Thank you.
Thank you, Rimpa. Uh, a very good evening to you all. And I bring greetings from the Indian College of Anesthesiologists and the Institute of Anesthesiology, Pain and Perioperative Medicine, Sir Gangaram Hospital. The ICA, the Indian College of Anesthesiologists, was started with the tenet of providing uniform standards of education and training for the students, and it has very senior anesthesiologists from the our specialty as its members who are actively participating in the academic activities, and they are being honored as honorary fellows, and this fellowship is given every year, and they are very active in the academic activities of the college, and the college is running fellowships in various subjects such as cardiac anesthesia, onco anesthesia, regional anesthesia, and fellowship in palliative medicine across the country. And our number is increasing, and we are holding this webinars, national webinars, which has become quite popular. And the aim of the college to have uniform standard of training for all the students, so that we are at match, with the we can match the global standards. And today's topic is very relevant. It should be very useful for our students. And Dr. Manjula will be moderating the session along with Dr. Shipra and Dr. Manjula. We are, well aware of her. She is very often on this platform, and presently she is working as a professor and of cardiac anesthesia at D.Y. Patil School of Medicine, Navi Mumbai. Dr. Manjula, please.
Thank you, Dr. Vimla Madam, for a kind introduction of mine to the audience. And today's topic has been chosen because our students are facing this problem, that very much by whenever they are giving any interview or going for any interview, for the selection of the post, the question is coming whether this super specialty is helping them or really not helping them, or it is creating the problem to them. So we thought, let us discuss this topic with our all great panelists, and they are all sitting on the prestigious positions, so they can just help the students that how they should proceed. So I would like to introduce my co-moderator, Dr. Shilpa Tiwaskar. She is very young, dynamic, and very popular lady of the city of Mumbai. And I think not only in the Mumbai city, but I think all over the country that people know Shilpa very well. She is holding the post of professor at Bhakti Vedanta Hospital in the city of Mumbai. So welcome, Shilpa. And without further delay, I would like to ask her to proceed for the panel discussion and introduce your panelist. So over to you, Shilpa.
Yes, thank you, Manjula Madam. Thank you for the kind introduction. Thank you, ICA, for the opportunity. Thank you, Vimla Madam and Vineet Sir, and even Sir had joined. So actually, I am a student of Manjula Madam at KM Hospital, and I would like to share my screen and introduce my esteemed panelist. Yeah, so our first panelist, Dr. Deepa Kane, madam. Madam is professor at St. GS Medical College and KM Hospital, Mumbai. And madam has areas of interest, regional anesthesia, cardiac anesthesia, and public awareness about CPR. Madam has more than 40 publications. And madam teaches CPR and regional anesthesia with compassion. We have next panelist, Dr. Mukul Kumar Jain, sir. Sir is professor of pediatric anesthesia at Postgraduate Institute of Child Health, Sector 30, Noida. Areas of interest, sir is interested in pediatric anesthesia, airway management, neuroanesthesia, teaching and training. We have a lot of publications of sir coming up, and sir has more than 25 papers in national and international journals. Sir is a coordinator of IAPA Fellowship and coordinator of FNB Pediatric Anesthesia at PGI Chandigarh, Noida. We introduce our next panelist, esteemed Dr. Kanagarajan Natarajan. Sir is current head of Department of Anesthesia and Critical Care Medicine at Institute of Madras Medical Mission, Chennai. Sir's areas of interest are pediatric cardiac anesthesia and perioperative transesophageal echocardiography. Sir has more than 10 publications, and sir is very popular among students for all his lectures. Welcome, sir. And next we have Gargi madam, Dr. Gargi Nandi madam. Madam is in charge.
Similar prominent lecturer like Asterisk Drive. GD Puri.
Sorry. Madam is in charge pain management department at ESI Institute of Pain Management, Kolkata. And areas of interest are interventional pain management, cancer pain, and pain education. Madam has also a lot of awards to her this addition in her CV. Madam has Scopes Award for Pain, and Madam has Professor Ashok Saxena Award for Best Paper Presentation on Neuropathic Pain. We welcome you, Madam. Thank you. Now, can we proceed to the panel, Manjula, Madam?
Yes, yes, please proceed.
Yeah. So my first question to all the panelists is, what are the super specialty anesthesia courses and degrees available in India in your subspecialty? Like if our postgraduate student has to do super specialty. So Deepa Kane madam, can I ask you, in regional anesthesia, what courses and degrees are available?
Good evening, everybody. It's an important topic. And for regional, coming to the topic, the regional super specialty or the fellowship courses that we have, one is the AORA, that is Association of Regional Anesthesia. It is started by the Society of or Academy of Regional Anesthesia, and they have their fellowship courses, 1-year courses all over the country, I would say. And I think, I don't know the exact figure, but they have more than 50 fellowships or more over the country. Then we have the Ganga Hospital fellowships, which are the Dr. Balavenkat sir's fellowships, which are about 6-month courses, and they also have plenty of them, 60, 70 or more. And we have the Maharashtra University Health Sciences fellowship programs, which we are running at KM, Sion, Nair, and some hospitals of Pune. So 8 to 10 of these courses are available. And then there are the short observer posts and 1 month or 15 days where people can go and spend some time. But those who already know the stuff may just go and observe for some time, and they can update their knowledge also.
So, madam, what degrees are available? Like, do I get a DM degree or a fellowship degree? And how many months they are? Like, what should I opt for?
So regional, so far what I know is the fellowship courses. We don't have DM in regional, but we have the fellowship. So at the end of it, you get a certificate, you have an exit exam and you get a certificate. So if it comes from the university, it is given by the university. And if it is by the Academy of Regional Anesthesia, it is the society which will give the certificate. Depends on the where you have done your course. So from student point of view, if you ask me from student point of view, like first of all, they should know their goal, what they really want to specialize in is one thing. What is their interest? And it is just for knowledge and uh, for their own progress, or it's one, stamp on the CV that they get, that is one thing. Or they are interested in research of that particular branch that is important for them. Do you want to get clinical experience? So if they want to know how much clinical experience they would get out of this, is important to know which hospital they will join, because there will be some hospitals which will allow them hands-on, like our hospitals. It's a public hospital. We allow our fellows hands-on. It's not just lectures, or it's not that the consultant only does. Our students are doing hands-on. So many hospitals give hands-on, so they should do that homework. And the best way to do homework is to talk to fellows who have passed from that institute or that hospital. That fellow will give a clear picture about how many cases are done per year, how many are hands-on for them, what sort of information they get from the mentor. They should also do a little bit of homework on their mentor itself, because they are, it's not only the learning environment is important. Most of them are post-MD, and many of them will be married. So they have other things to look at, how much time they are going to give for all this. Then how much, what is the program format? What is the infrastructure of that particular hospital? What is the desired job market? So like a thing like regional, it is very popular. And wherever you go, I think regional scores over many things. Like regional, you could use for anything. You can later on go into any type of anesthesia. You can use, like even if you're a pediatric anesthetist, regional always helps. If you're a cardiac anesthetist, regional will help. So regional, you can give anywhere in the body from top to down. So it is always of use. Then also the financial impacts of all these specialties, whether it's regional, pediatric, cardiac. So they have to look into all these issues, and what is the cost to them also. Some of them, like somebody is like passed from Bangalore and getting a seat in Maharashtra, they have to relocate. So if they have to relocate, and if they're married, whether the spouse can come, whether the child can come, they have look. I think they should be prepared for all this. What is the stipend they're going to get, or are they going to get a good amount of pay? Their family needs, their lifestyle, their work-life balance. I think they should take into consideration everything when they make these decisions. And besides the mentor, the feedback from their peers is very important to make all these decisions. Because with all these fellowships and these super specialities, there is, of course, the positive impacts are many, but there are some negative impacts, which I will talk later. I think you can ask the other panelists.
Yeah, so very important point that before joining, they should know about the institution, the mentor, and they should talk to their peers. Yeah, over to you, Dr. Mukul Jain, sir. Regarding pediatric anesthesia, I think pediatric and cardiac were the earliest ones to come. So what I see many people sometimes doing just 6 months course, some are just doing observership. So what courses are available, sir, throughout the country?
Thank you, Dr. Shilpa. And there are a variety of courses available in the pediatric anesthesia, especially a 3 years degree course as DM, pediatric and neonatal anesthesia, recognized by NMC, and also run by AIMS its own, and PGI Chandigarh. Then FNB 2 years program is also available in pediatric anesthesia, which is recognized by National Board of Examination. Further, there are so many fellowships, IPA fellowship, Indian Association of Pediatric Anesthesiologists, accredited 1 year fellowship, or Maharashtra University of Health Sciences 1 year fellowship, which is limited to the Maharashtra only, I think so, because I had never met with any fellow having the fellowship from Maharashtra in my career as pediatric anesthesiologist in the last 10 years. Beside this, also ICA fellowship 1 year, again WFSA fellowship, that is 6 months, So there is the variety in duration of time in curriculum of the subject. And as Dr. Deepa said, I agree totally with the Dr. Deepa that any candidate should take all the clearance from the department about the mentor, about the course available, about the facilities available. Because in my view, the ideal institute for the pediatric anesthetist should be having the substantial load of the especially neonatal patients, and having the facility of neonatal or pediatric ICUs, and NORA facility for the pediatric patients. It is important because pediatric patients are not small adults. So it is very important that these courses should be streamlined and totally should be focused on the pediatric patients and neonates.
Yes, sir. As rightly said by you, NORA is also a very important part of pediatric anesthesia and the ICU part, the neonatal part and ICU part. So what do you feel the postgraduate should go for which degree? Like if I'm a fresh MD pass, then should I go for a 3-year course or a 1-year course also covers everything?
Yeah. Actually, because NMC has recognized pediatric anesthesia as a DM course, it is important if you want to be a faculty in the pediatric anesthesia, you have to do 3 years degree program, because
Okay.
NMC recognized only these persons for the faculty. Otherwise, they will not consider.
Oh, that's a very important
But
information.
for practice, obviously, 1 year program may be a gap bridge to provide the facility and education about the pediatric patients and neonatal care.
Yeah. Gargi madam, so over to you. So I wanted to,
Actually,
yeah.
pain medicine a bit different from these type pediatric super specialty wings of the anesthesia, like the cardiac and a pediatric like that. But it is pain medicine is totally different from that, because in we can see that in the Morgan there is only one chapter is dedicated for the chronic pain, and now ICD and WHO is considering pain as a disease, not like a symptom only. So it is little bit different, and in this stream you can go for the chamber practice, and you can make an independent practice in this field. And now in India there is a DM course in pain medicine. I've started in AIMS Rishikesh, AIMS Mongolgiri, and AIMS Gorakhpur. This is the 3-year DM course which is recognized by the MCI. Then there are some FNB courses, 4 to 5 hospitals all over India. They are doing the 2-year FNB courses, which is conducted by the NV. And
So
then
all these courses are there on the website, any website?
yes. You can search in the INSSS, where you can find the prospectus and all for the DM courses, and in the WBMS site you can easily find the area in the places where the FNB courses are running. You can easily find that. And there are 2 university conducted courses for 1 year, and one is in our institute that is affiliated by the West Bengal University of the Health Sciences, and one is the Maharashtra University of Health Sciences, which the course is conducted by Dr. Lakshmi Vas ma'am in the Ashirvad Pain Clinic, Mumbai. And there are some PDCC courses, and this is also a 1-year courses, 1-year course. And almost 10 to 15 renowned hospital, they are conducting the 1-year PDCC course. But the according to the NMC norm, these are not actually affiliated or accredited by the NMC. Only the
Okay.
only the DM course that can be added as the additional degree in by the MCI. Okay.
So, as Mukul sir said, only DM can become a faculty in pain also, or how is it?
No, not like that. If you have experience of teaching student of pain medicine, because till now it is not an established field, and there are just I think 2 to 3 students are just completed the DM courses from AIMS Rishikesh, and from this year only the AIMS Gorakhpur and AIMS Mangalgiri will take the student for the
Okay.
DM course. So till now it is not a big problem. Hmm. But I think near future it will be the same thing happen in this field also. And there are some 1 year observer, 1 month observership, and 6 months, 4 months fellowship by some renowned doctor on all over the country. And like,
Thank you so much, madam, for that. And we welcome Natarajan sir. Sir, in cardiac anesthesia, I think now it has become a totally separate specialty. Like most of the hospitals have cardiac anesthesiologists attending their bypass cases. So, what would you suggest a postgraduate student who is looking forward for a cardiac anesthesia course? What should he do? What courses and degrees are available? I'm not able to hear you, sir.
Yeah.
Yeah.
Good evening, everybody. See, basically, I don't know when the one thing which I can say that whether when the cardiac anesthesia even as a branch started, because the first textbook of cardiac anesthesia was written in 1956.
Okay.
So that is the one
That
thing. That is that old. Second thing is now cardiac anesthesia has become a specialization in a sense that the number of cardiac surgeries and the branch out of the branches, like what you call a minimally invasive cardiac surgery, then you have a ECMO, then what you call mechanical circulatory support in the form of a transplant and the LVAD. So much it's branched out that now the cardiac anesthesia branch is a well-established one. So it initially it started with a 1-year PDCC course. Now also you are having
what is that PDCC?
Postdoctoral certificate course.
Okay, so it is just
It's
after.
after MD, you have to do 1 year, and most of the time, initially which was started as an institutional course, now it is attached to the universities. For example, in Tamil Nadu, it is always attached to the MGR Medical University, Tamil Nadu MGR Medical University. Then it started with the FNB, 2-year course, Fellowship in National Board, 2-year course. Now it moved into a DM or a DRNB 3-year course. So now it is almost like 50 to 60 seats of DM and DRNB in India. And then if you are coming to a institutional base, like an association associated courses, like the Indian Association of Cardiovascular Thoracic Anesthesiology, that's in IACA. We have a 2-year fellowship course.
Okay.
And it is a well-structured course where for an adult cardiac anesthesia practice, it is a well-formed. The structured means what I said was that to complete the course, for a logbook, you have to have this many number of adult cardiac cases, this many number of pediatric cases, this many number of cath lab procedures. So it is not like a fellowship which is just offered for anybody. It is you have to register the course and you have to fulfill the 2 years, and then you have to have a logbook, which is very essential for you to clear the exam. So now the cardiac anesthesia become like a well-established scientific principle which is very, very popular. Because to be honest, when you do an MD, all other coexisting diseases, you are not much worried actually, like a pediatric neuro or even. But when it comes to the cardiac cases for a non-cardiac, there is always some hesitations when you manage that kind of patients. That's a fact. That's why cardiac anesthesia training is very important for not only doing a cardiac cases, maybe more important in when you do a cardiac conditions with the patients coming for a non-cardiac also.
Yes. So that's a very, yeah, madam, over to you.
So after listening to all the panelists, student has to decide what kind of the practice he wants to do, whether he wants to do the only clinical practice in the private setup or in the private nursing homes or in the corporate sector or in the institutional higher positions. So according to that, he has to decide which course he wants to do it. When we started all these courses, they were the sub-specialty courses, as Shilpa has already mentioned it. But now all these courses are the super specialty courses because the duration is increasing for the each course gradually. So we have started with the 6 month, then 1 year, then 2 years, and now the 3 years. So if the student is just spending 3 years duration of the time, definitely he has to learn the advanced techniques for all the branches. So super specialty means that only that we have gone ahead, and the student has to decide on which direction he wants to go. Pain is a separate subject now. So first the super specialty course has come in the cardiac, neuro and pediatric, and now we are just extending in all other branches too. So I think Shilpa, now you can proceed for the second question and ask.
Okay. Okay. Thank you.
One small comment, I was
Yes, sir.
coming across an interesting thing that American board for the all these specialty posting, they almost have a 60 courses in after your anesthesia specialty.
Correct.
So,
Okay.
so that much it's branched out basically.
Yeah. Yeah. So we have questions regarding that, whether we should need to do that. So I have just summarized. So there are DM courses in pediatric and cardiac, and fellowships in and DM courses are coming in pain also. Fellowships are there in private hospitals as well as national board, and MUHS accredited are there. Then I have just summarized from internet what I have got regarding the regional, pediatric, the cardiac, as sir said, postdoctoral certificate course it started, and then fellowships and then DNB, even for pain. Now there are DNB courses, and for regional, pediatric also. Anyone wants to add anything to this?
No, actually, in pain, there is no DNB courses till now.
Not started yet.
Yes, they are not started.
Okay.
And
so, as you said that I visited that site only, so I'll just recheck again.
And in pain, the DNB has started fellowship courses, and at Gangaram, one candidate has cleared his exam also.
And madam, I think, yes, madam, that is the FNB course actually.
Yeah, sorry, DNB, but from the national board. Yes, you are right in a way. Yeah.
Yeah. So now we already saw that which universities run these courses. Now, coming to the important point, is there any regulation given by National Medical Commission that this should be the course, or this should be the candidate must complete this many pain procedures or this many cardiac procedures? Like for DNB exams, we get the syllabus. So is there any syllabus given to private institutions, to corporates, or to the government medical colleges who are conducting these courses? And secondly, as we were discussing, is there any accreditation, like suppose a corporate hospital is conducting a regional anesthesia course. So is there any accreditation to the private organization as well as to the university? So first would like to know about the regional. Deepa madam. Is there any regulation given to you?
Actually, the syllabus is given by the university, or if it's a society related fellowship, it will be decided by that particular society. Now, NMC accreditation, actually, even our fellowships are not NMC accredited. Even
Okay.
the society fellowships are not NMC. I don't think they are NMC accredited. So, if we
Okay.
want that accreditation, then we have to apply to them. Then they will look at everything and they will make a decision whether they can give that accreditation, or they will tell these other points which you don't have, this is what you have to add. And then, so it is up to the university to ask for or the hospital to ask for the NMC accreditation. So far, I don't know about the IDRA. We have the Indian Diploma of Regional. I don't know if they are NMC accredited, but EODA and our fellowships are not NMC accredited.
Okay. And is it that the corporate hospital anesthesia, the surgeons or the private nursing home surgeons, they would prefer this for specific cases, they would prefer a regional anesthesiologist only? Like suppose I'm doing a spine surgery and someone regional anesthesiologist is there in my complex, along with me, then they would request them to give a erector spinae block or something.
See, let me
Or-
comment about that the same question which you asked for the accreditation.
Yeah,
See,
yeah.
NMC will always compare your fellowship with their DRNB and DM course.
Okay.
For example, if you are having a fellowship course in your association sponsored program, it's only 2-year program. Okay. Even though you are having a selection criteria and you are having an exit exam, but you don't have a thesis and you have only 2 years. So it's very difficult to get accreditation from the NMC for a equivalent to your DM course. Because now, if you look at most of the fellowship courses which was approved by the national board, converted into a DM course now.
Okay.
You are having only a fellowship course, only few specialty, and that also sometime post DM basically. For example, fellowship in interventional cardiology, fellowship in reproductive medicine. So you don't have a post MD fellowship which compared to equivalent to the DM or DRNB run by the national board. That is one problem.
Understood.
One problem with the accreditation get by the NMC.
See,
Second thing,
NMC, I think NMC has its own guidelines for
Yes,
giving the
yes.
accreditation,
Yeah,
and
yeah.
for that you have to apply it. And if the corporate sector or the institute is not fulfilling those criteria, then they are not going to give the accreditation to that particular course. So for that particular course, you have to just do the checklist and then apply for the accreditation, and then NMC gives you accreditation. But accreditation courses are really very limited. They are not, that so many courses are running. Everybody is starting from the university side, from the corporate hospital side, or from the society side. They are not accredited course. They are very limited number. And that is given on the NMC website. If you go to see that, then you will come to know what are the courses accredited for that particular branch.
And
Madam,
Yeah.
once we tried to get accreditation for the our pain fellowship, but they clearly told that no courses less than 3 years they will
Correct.
not.
Is
exactly,
correct. Is
exactly.
fulfilling the
And
criteria.
second thing is, it is very easy to get a university affiliated courses because
Correct.
even the university affiliated courses are having a proper syllabus and exit exam. So
And does this
See, when
university?
you want to apply for the university site also for any course, right? They are going to form a committee, and then committee has to just go and check whether the things are as per the rules are not, then only they give the approvals. Otherwise, they don't give approvals. And whatever things are lacking, they will say this is lacking, you have to fulfill that. And then only the course will be accredited. Second
Yeah.
thing, you have to take the government permission also. So that government health sector has to approve that course, and then only it is going to be accredited. Otherwise, no.
Yeah, there
So
will be
these are
always
the
a-
limitations. These are the limitations.
always there will be inspection by the team of
Correct.
government doctors, government
Correct.
specialists coming to your institute and give a clearance for your PDCC, even
Correct.
if it is a 1-year course. Yeah.
Correct.
Okay, so students, I think, will be happy to know this, that all the courses are even monitored by the government, by the university. And one more thing I wanted to ask Natarajan sir. Sir, you just now said that if it is to be accredited by NMC, then it requires a thesis. But some courses do have thesis. Do they have, like,
No,
even if they are
no.
1 year?
Most of the PDCC and FNB courses, even conducted by our own association, IATA, doesn't have a thesis. That will
Only the
be,
DM ones.
yeah, only the DM or DRNB will have a thesis. That is
You
one of
can
the
do
big,
the dissertation or publication.
Any research work.
yeah.
Any research work.
So that is going to be one of the limitation when you are applying for the accreditation.
And that
Okay.
research work has to be registered with CTRI. Then
Yeah.
only that registered
Always,
research work
always,
will be
always,
taken into consideration.
Yeah, always. Yeah.
Yeah.
Actually,
Yeah.
in IPA accredited fellowship, that is a 1-year fellowship, candidate should have completed a research work
Okay,
within
great.
1 year.
Oh, that's a good thing actually. Yeah.
Good.
And
We have
this is
research
more
for-
structured program in all
Okay,
number
so
of
can you
cases.
tell us more about that? Like, how do you get the thesis topic approved? From which, like, your own approval, or you send it to university? We send it to CTRICI also. Yeah.
Actually, we have our ethic and research committees in our institute, and
Okay.
through that we get the approval. The committee have the external experts and other areas also, like legal cell, etc. And after the approval from these committees, the research may be conducted.
So when you apply for the CTRI registration, at that time you have to show the local ethics committee permission letter, then only they will register. Otherwise, they will not
Yes, ma'am.
register. So
Yes,
in
yes,
first
ma'am.
step, you have to take the permission from the local ethics committee. Then you have to apply for the CTRI registration. Correct?
Yes, madam.
So
Yes,
this
madam.
is for all the branches.
Yeah.
Actually, in
Yeah, so-
our course also,
Yeah.
we have a institutional ethics committee, and our student also do a 1-year dissertation, and
Okay.
we have a
So
some
I think this is
number
the standard practice.
are,
Everybody follow the same, I think.
and keep there are some 10 or 20 marks for in their exit exam
correct.
for that publication.
Even for MD exam, now they are keeping 20 marks for the dissertation and your research work separately. So you have to discuss that, and then only you are going to, that is one station, I mean to say.
Okay, yes, that is one station in practicals. Yeah, so it is really good to know that the courses such as pain and pediatric, they also have dissertations, and though there is no NMC accreditation because there are very stringent rules of 3-year course, but still these courses are accredited by the university, by the government, and we have people observing the centers and then giving accreditation. We move on to the next question. Now, I have passed my MD in 99. So what hunts me is that are these fellows who are coming, even joining my hospital? So is this curriculum, I'm not doubting it, but of course, it's a super specialty, but is it required after MD? Deepa Kane, madam, what is your opinion?
Yeah, so there are always plus points and minus points to everything. Now, super speciality, it does give you specialized training. So the expertise of that person will be really good for that particular field. The knowledge would be really advanced. And when you have very complex cases, it becomes really a need. So like cardiac, pediatric, with the DM courses and all for complex cases and everything, it is excellent. And and the career opportunities also are enhanced. Like if you have a
Like, I would like to interrupt you. For example, when I did my MD, I had junior posting in all this. I had senior posting in all this. And when I passed out, I could do pediatric. I could do 1 month old child also. So, or I could give regional anesthesia. That time, of course, it was a blind procedure landmark guided, but I could give for all my cases. So, my intention is like, uh, why the need is there? Is there any special curriculum that we are looking at?
Yeah, so for really complex cases, or being a real expert at a particular thing, basically you need to do the same thing again and again and again. So if you do the same thing over years and you read more and more, suppose only on cardiac, and you attend conferences on cardiac, workshops on cardiac, your knowledge would be excellent, and then you will be really one of the best for that particular field. But as you rightly said, Shilpa, if you look at the MDs that we created like your time and the MDs that we are creating today, there is a stark difference in the two. Like the MDs that we created even 15 years back, I can surely say were much better than the MDs we are producing today, because those MDs had very good hands-on in cardiac cases, pediatric cases, and they would do all sorts. Now, so many cardiac anesthetists of your age, they're only MD qualified with good experience in cardiac. They do, mainly they would do CABGs, valves, or interventions in the cath lab, and they do it as well as the cardiac anesthetists, I would say. And the MDs of those days would, sir has also said, Natarajan sir has also said, it's important to have that cardiac knowledge for non-cardiac. They would be excellent those days. Even pediatric, they would do neonates and small babies, 1 year old, with ease, because they would get that much hands-on. Now with this DMs and fellows coming up, all this work is going hands-on into the fellows and the DM candidates, and our MDs are getting less hands-on. Suppose in my own institute, I feel they get less hands-on on the cardiac work or the pediatric, though even we post them there, they are more like observers, because the hands-on goes to the fellows and to the super special. It's going to happen in any institute. So the MDs that we are producing today, I would say, are not of that quality that we produced 15 years back. That is my point. So
So,
that
Gargi
is
madam,
a big advantage that yes, super speciality will improve, and super speciality cases may be done in a better way, and more complex cases may be done. So that is the advantage. They may have advanced knowledge, those who have done through that DM, or they would be better. But there is a negative point to it also for the MD candidates.
So, Gargi madam, I would like to ask you, for pain, it is adding to the MD curriculum, right? In MD, as you said, we have only a few pages of pain medicine,
Yes.
and we don't have so much exposure. So, what you feel, it is must after MD, the pain fellowships? Those.
Actually, when I did my fellowship after completing my MD anesthesia, then my focus was only for the intervention. But when I am going to the deep into this field, now I am my thought is that it is a totally different from anesthesia. Actually, Uh, it is it should be a broad basic specialty, because it
Okay,
is
okay.
totally the understanding of chronic pain is totally different from the acute pain and from the anesthesia. Because what I have just told that now it is now it is considered as a disease. Chronic pain is considered as a disease in the ICD-11. Just 2 to 3 years back, the ICD-11 has come up. So
Yeah.
in there, that is the primary pain, which is considered like a disease. So the pain.
So your fellows are adding up to their MD knowledge by, sorry, by doing the detail work in pain.
Yes. And the 1 year is not sufficient to study the pain medicine, actually.
Do you have OPDs also? Do they have to
Yes,
attend?
we have OPD, we have the inpatient department in our institute for only chronic pain and cancer pain patient, and we have dedicated OT for pain medicine also.
Okay, Natarajan sir, what is your view as Deepa madam was saying that the MD candidates who passed 25 years back, say, or 15 years back, could still handle the cardiac cases? What do you feel?
Yeah, that is true if you worked through the MD in a area where you have a cardiac anesthesia or
Okay.
cardiac surgical department. Okay, because if suppose somebody is asking me that why do you call yourself as a cardiac anesthetist? I can say that three areas. One is a cardiac anesthetist is well versed with the cardiopulmonary interactions. Okay, he
Okay.
knows about the in and out of the cardiac physiology of various diseases. Second is the monitoring. The cardiac anesthetists are well versed with the monitoring, including the every cardiac output monitoring what you are having. Third is the intraoperative echocardiogram. So a cardiac anesthetist is well versed with these three areas. That makes him much more better than even the so-called MD anesthetist or a specialty who worked through the various cardiac conditions, who can even manage a cardiac condition for a non-cardiac surgeon. That is the difference between a cardiac anesthetist and the non-cardiac anesthetist who are well versed with the cardiac anesthetist. Because here you are getting an expert who can reaction time is better, monitoring and then invasive monitoring, everything is better. That is why this cardiac anesthesia training makes you better whether you are doing a cardiac anesthesia or non-cardiac. That's
Yeah.
see,
Very important point, sir. Yes.
25 years, yes. When I passed out, if some patient comes with an atrial fibrillation or with a moderate MS, okay, fine, I would be able to manage. But now my understanding of the same cardiac physiology and managing the same patient and improving the outcome is much better than what I would have done 20 years before.
Here
That
I would like, let's
yes,
continue.
madam.
Here
That-
I would like to say at the time of Shilpa, you must be able to conduct all the cases whichever comes to you in outside practice after doing your MD anesthesia. But that was the basic anesthesia. Now it is subject specific anesthesia. So if the patient is having any cardiac pathology or the pediatric person is coming to you for any surgery, who is having the cardiac pathology, or the pain person is coming to you. Pain is, that separate department. They have their OPD. They are doing all the procedures under CT guidance, and also the things has changed. Things has changed. So if you want to do any specialization, you need specialized training, which you are not able to do it. I am 100% sure. And when we were giving the regional anesthesia at your time, we were just doing the supraclavicular block or interscleneous block. Now each and every part of the body with ultrasound machine is getting blocked, whichever block is required. So the things has changed definitely, and for that you need special training. You cannot say ki I was doing it like this, so that my student will also do like this. No, it is not like this. It has changed drastically, and you have to accept the change. This is what I would like to say.
Yes.
Yeah.
So what important thing Natarajan sir has said, in-depth physiology about the cardiac and the respiratory things, the trans echocardiography and the specialized monitorings, cardiac output monitorings, which these fellows are learning more. Dr. Mukul sir, I wanted to know now, pediatric anesthesiology organizations are there even in Mumbai, and for specialized cases they are called. So now even I was able to do, as I said, after MD, I would take a 24 number IV even for a 1 month old. But now for a 1 month old, my surgeons prefer a pediatric anesthesiologist. So what's your opinion? What's different than the MD curriculum?
Actually, as I already said that pediatric patients are not small adults. they have the different physiology, anatomy, and their congenital anomalies, cardiac disease. So many factors are attached to with these patients, and so in pediatric anesthesia is definitely very critical and difficult aspect of the anesthesia. I think so, and it is better if in Maharashtra it is already practiced that pediatric anesthetist is called for the pediatric patients.
Yes, yes, very much.
Uh, but in our side, particularly in UP or Delhi, I think there is no such has been accepted till date, and time will change. And definitely pediatric anesthesia will do the pediatric anesthesia for the pediatric surgery patients in coming time.
So you feel that you have added something more to the curriculum than the MD curriculum in your fellowships?
Yes, madam. Definitely, as we ask the students to make the drugs dilution and dose according to the patient age, because there is difference in neonate and pediatrics age group also, and in pediatrics with year also, and we also provide regional anesthesia by ultrasound for because we use multimodal analgesia and anesthesia for these patients. We do regional as well as general anesthesia in all patients, and this will also provide post-operative pain.
Okay, and also we have a lot of babies coming with congenital abnormalities and difficult
Yeah, definitely,
intubations.
definitely.
Okay, over to the next question. Yeah, I think this madam has already asked, does it make any difference between a government or a municipal hospital fellowship or a private association or a corporate hospital? And in a corporate hospital, this is what I've heard. I don't know that since the patients are paying patients and they want to be totally unaware. So even after a block, general anesthesia need to be given.
Fellowships in government / municipal
I'm so
hospitals.
sorry. I'm so sorry. My AI is, I think, getting activated. Yeah, and in also for pain fellows, I wanted to know, Gargi madam, like after how many days do they actually get hand-on? Suppose a pain fellow is coming to you, he has to first understand. So does it take 1-2 months or within 7 days? And for cardiac fellows, I wanted to know how when they can start doing cases alone, even for pediatric. So can we start with cardiac? Natarajan sir, when do you
See,
feel your fellow can do the
see,
cases alone?
see, basically, it is not like where you do the fellowship. Okay.
Okay.
The most important thing is the case load and the facilities what you are having. The only problem in government setup is you are limited with your resources. Okay. The cases may be more, but the monitoring aspect may be slightly less.
For
But
cardiac.
for cardiac, yes, I'm talking only about cardiac. But if you are working in a high volume center, let me take my example because I cannot talk about the others. We do almost like a 2,200 cases in a year. Okay, that means almost like 10 to 12 cases a day. And my guys will be able to manage a case in from the second year onwards. First year, definitely you need 1 year of your own experience with your consultants to be an individual man. Because I passed out only with the PDCC in 2001. And in the 1 year PDCC, I have assisted almost like a 350 cases. So in a cardiac, if you are working in a high volume centers, you need lesser time to become an independent. Suppose you are doing a lesser volume center, you might be taking more time. Because in a cardiac, it doesn't make a difference whether the paying patient or a free patient. you will be allowed to manage the patient under supervision for a particular time. Then after that, you will be allowed to manage a case with what you call less supervision. Means you will be allowed to come off when the consultant just standing behind you, allowing you to come off from the pump. So,
Okay.
the important thing is that what is your facilities and infrastructure and the number of cases that going to make you faster to become an independent.
Okay, that was really good, sir. Deepa, madam, your take on this, like
So
first.
same thing, no, that is what I also said in the beginning, that the students have to do this homework. What is the caseload of that place? Who is the mentor, and how many, what infrastructure do they have? Like for a
Okay.
regional, like we should have the ultrasound. Without the ultrasound, I think regional is very incomplete. So this basic infrastructure and how many other cases done and how many cases they will get hands-on. These three questions have to be answered to join any place.
Okay, okay. Mukul sir, you have to say something.
Yeah, actually, at our center, we also provide the anesthesia to cardiac patients, particularly pediatric cardiac patients, and we independently and solely uh, give the anesthesia services to the pediatric cardiac patients. Though
Okay.
it is very difficult, but uh, students doing the FNB or 1 year fellowship, after the end of 1 year, uh, usually come to up to the mark that they can uh, 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 manage such patients also.
Okay. Mhm. So at initial, at least 6 to 8 months, they don't do alone cases.
Yeah.
Okay, fine. And Gargi madam, about pain.
Actually, the infrastructure and the mentor, these are the most important things. I am in a government hospital, but for pain, we have a high-end radio frequency machine. We have a 1 crore serum machine, own USG, PRP, ozone, everything I have. And in no corporate hospital in my city, uh, no one have this type of infrastructure. And we have a also good department, indoor bed dedicated for pain and everything. So these things are more important when you choose the institute or choose the course actually. Hmm. And in our institute, what we do, that first 3 months we the fellows only assist uh, the cases with us, and after that we give some facet joint block or caudal block, like the very simple things. And last 1 or 2 months we give the trigeminal neuralgia, radiofrequency ablation, or
Okay.
typhoplasty. But always there we supervise the cases and all. So this is
I
our
think
structure.
apart
Okay, so
from the
after
infrastructure, the students' confidence level and knowledge and attitude towards the work is also very, very important, because that 3 months, 6 months, it hardly matters. If the student is good enough, they can learn in 3 months of the time and they can do independent work. Many a time, even we are giving them the work after 3 months also. So student personality also matters according to me, apart from all these factors.
Yes, yes, very important. Yeah, we see differences between our students also. Someone who is really willing to learn, someone who is passive. Yes, now this is the main thing which I wanted to know actually. So this, after they are post MD, so do they get stipend? Mukul sir, now a
Uh,
fellow comes to you. Does he get a stipend? Does he have a
yes,
leaves defined per year? Yeah.
actually, we are a government institute and we give the salary of senior resident to them,
Okay.
to the fellows or to the FNB, can, or after getting the DM course, to all these.
And do they have to do
All
on-calls, emergency?
all in UP there is the bond for the DM candidates only. For fellow or FNB, there is no bond, and all the leaves as per the government rules they will get.
And while suppose a fellow is working with you, but is he allowed, or if he wants, he can go to do the other cases while on training, or he can be also sent to the OPD, like, or it is just dedicated to your department?
Because our department is separate department, we have the candidates under our own
Okay.
supervision only.
Okay,
And
fine. And they have to do emergencies also, stay
yeah,
there?
yeah.
Okay, Deepa madam, how is it at your place?
So we gave them the SR post, the senior resident post, so that they are paid, and they have to do emergencies like any other emergencies also. Once a week at least they do. So they may have to go for any other case besides
Yeah, that's what I wanted to know.
orthopedic and obstetric. They may have to go for any case. And they
Do
have
they have OPDs?
OPDs. Actually, it's only the pre-anesthetic checkup of patients who are there posted. But suppose there is a need in the OPD and it's a washing day or something, we may put them anywhere. It's like they belong to the department, so they have to go for any case, anytime, as per the need. And if they want to go and see some other institute, we always encourage them to go to other institutes also and see how people are doing things. But they go at their own cost. We may give them some leaves, that's all. But they go at their own cost. And
Okay.
because going somewhere else also, if it is within the city, then it is they stay at home and they can go. But it is outside the city, that means they have to arrange their own accommodation, stay and all that. So, but we allow them, we encourage them to go and see other institutes also.
Okay, in your institute also, on call days, they're allowed to do other cases.
Yes, we are allowing them to do. We make them do the other cases also.
Okay, okay. Gargi madam, how about your fellows? It's a separate department, or it is attached to
Yes.
your college?
No, it is a separate department, and actually we do not have any emergency duties, and acute pain service is taken care of by the anesthesiologist of the hospital, and they have to make sure that their 80% attendance they should achieve. So the leaves are like that, and there is no need to do the other cases or other anesthesia cases, as we have a separate department for the pain medicine, and we have own pain clinic, pain OPD for once a week, and for the rotatory thing, we send them to the rheumatology department, to the neurology department, to the radiology department for the understanding of the MRI, CT scan, like that.
That's good.
And for the cancer patient, we are sent to the we have a National Cancer Institute where they do the palliative thing also.
That's very nice. But you said post-operative pain is managed by the routine anesthesia department.
Yeah.
So your fellows aren't taking rounds about that.
No. For the emergencies.
Okay. Natarajan sir, I wanted to know from you.
I can say that one negative aspect or a deterrence for the people to join cardiac is the long hours. Because
But if they have a passion, then it doesn't matter.
Yeah, it doesn't make any difference. But the problem is, the advantage is if you are working in a high volume centers like where the DRNB students are more. For example, I have 4 DRNB students every year. That means at one point of the time, any point of the time, there will be a 12 students.
Yes.
So it is not going to be that kind of taxing for them. Well, yes, they get a stipend almost like 85,000 per month. And they have
So do you allow shift duties since you have 12 students?
No.
No, the morning people and then the afternoon.
They can come little late, but I don't give them the exactly shift duty because I have a 7 theaters. So it is almost like the morning starting will be around 8 o'clock, and the second round will be almost like 11 to 12 if there's an op cab and if it is a
Yes,
van.
yes.
So I don't give them the fixed time, but it is a flexible timing for them. They get a 30 days leave as per the DRNV,
Okay.
and but they won't be allowed to do any private practice or going to the non-cardiac. We have a separate department for a non-cardiac, and rest of the traveling, leave, conference, everything as per the institute policy. Yeah.
Okay. And
Yeah,
do they have to?
Dr. Natarajan, I differ from your opinion regarding the timings are concerned, because the CABG case, which was going for 12 hours in the past, right? 10
Yes,
years
sir. Yes, sir. Yes, ma'am.
past.
Yes, ma'am.
Now they are finishing in 3 hours of the time.
That is what I told. Suppose if I'm doing a pediatric, like an arterial switch, I may have to work.
Even for the arterial switch, you know, that I remember those days when the post-operatively we were shifting that patient, and patients were going into pulmonary hypertensive crisis, and for the, you know, that 24 hours, they have to ventilate the patient with ambu bag and all. We were not having the ventilator. So those scenarios has changed totally. And now we are working with lot of advanced facilities.
I can say that there are two things change in the over a period of time. Even now, when you are getting a candidate, they first come and ask me that how many cases I do. The first question they ask.
Hands on, they will ask.
Yeah, then they will ask that, do I get some off? Then they will
we
ask
are
that.
giving them off, na? We are giving them off. We are
Yeah,
giving them off.
but when you were the student, you never asked these kind of questions.
Exactly.
Okay?
So that things has changed. Things has changed, and we are trying to keep them as comfortable as
I
we
agree with
can.
you. I agree with you.
And even they are asking for the fixed hour duties. So if their duties, you know, finishing in 8 hours, if they will, they are supposed to be there for 9th hour, they will ask, Madam, duty is over. So, okay, we are trying to, you know, relieve them. So the things has changed a lot, but that is the general attitude for all the subjects, not only the cardiac
I agree
or
that,
the pediatric.
but usually we are little bit high volume center, so we tell them that as much as possible, I will try to relieve them and have some time for the family, everything. But when it is needed, they have to work a little more extra. So
correct. So as per need, they have to do the adjustments.
So they understand that actually. It is like a give and take policy nowadays actually.
Correct.
And do we have emergencies like some
Yes,
re-explorations and all?
yeah.
So you have them on calls.
The registrar stays at the hospital. The students stay at the hospital. The consultants is on call. So they come from the home. Yeah.
So, okay. So one student means whoever who's doing the fellowship is always there in the hospital.
Yes, always there. Yeah.
Okay. Mukul sir, what you have to say on this?
Because I think in case of emergency, when call received, the student should have ample time to assess the patient, particularly in pediatric cases, because as Dr. Kanagarajan said, that we remain on call, but in pediatric cases, we generally attend the call with our fellow during the emergency cases also. And till when then they reach, he should be or she should be completely aware about the condition of the patient, about the general status of the patient, and for this, the student should be in stationed there only.
Oh, so you have on-call duties, Rota, there. Yes. Okay, great. And yeah, now this question, do administrators prefer candidates with fellowships over others? We have in our institute also, we have one madam who has done cardiac fellowship, one who has done regional fellowship, one who has done pediatric fellowship, but they're at par with, like, they are doing cases with us. So is it that nowadays the corporates prefer candidates with fellow? What do you say, Mukul sir?
Actually, we are now bound with NMC, and NMC said that only candidate with 3 years in pediatric anesthesia experience can be a faculty in department. Presently, I have 11 posts of assistant professor and 5 posts of associate professor in my department. But due to such guidelines by NMC, I am unable to fulfill these posts. I have
Oh,
2 assistant professors, one from uh, PGI Chandigarh having the DM pediatric anesthesia, and one from KEM Mumbai having the same DM course. But other post I am unable to fill because we bound totally
okay,
with
okay.
NMC.
Yeah.
And recently, one candidate is also selected having the DM from KEM. Uh,
Great.
so,
What do you have to
as
say?
as
Yeah.
administrator, we cannot prefer fellow or other in our institute.
Understood. Gargi madam, even what about your this? Does your institute prefer the fellows who have already done their fellowship in pain and then they take the fellows, like, since there is a separate pain department. So when they are hiring, do they have this?
Actually, yes, as there are not many who are finished their DM courses, so we prefer the candidate with fellowship. We prefer the any FNB fellows, or any who have finished their fellowship by any reputed government hospital or any university accredited courses. We
Okay.
prefer them actually.
Deepa madam, when a candidate comes to you, suppose we have to take a lecturer in Department of Anesthesia KM Hospital. So if the candidate has done a regional fellowship, do you prefer him to take in the orthopedic department, or how is it?
Shilpa, I want to tell you one thing. Right now, we
Uh,
have 10 vacancies for lecturer post. Please send
uh,
me 10 people who are only MD. I'll take all 10 of them. There is so much
okay.
shortage. Understood? And we want the work. We will teach them. Send them to me. I will take 10 of them right away. We will have a interview
Wish
soon.
I could become
Please
student
send
again.
them. We will teach them everything. Means what we do, the general anesthesia work, we will teach them. So for as if they are running the DM course, you are bound by the NMC and you have to follow their rules. But for regional, we are not running any DM course. We can take anybody. And for the fellowship, yes, we follow the rules of the university. But for a lecturer post, we don't have to follow anything. They just have to be and finish the SRship for 2 years. That is the rule. And an MD candidate, we can take them. Unfortunately,
Means,
we are
would
not
you
getting
prefer if
candidates.
someone
I'm
has done
telling you, the
regional?
problem is we are not getting candidates. We have to look at our problems also. We are not getting candidates. Please send them to us. We'll take everybody. What you are
Okay.
saying, yes, if I have 20 candidates and I have to choose 10, I will choose those with fellowships. That is the answer. But the point is, you are not getting 10 candidates.
Okay. So
You have to
people are
look at that
preferring
point also.
So here,
preferring to.
basically, if the candidate is having the DM degree, that candidate will be get selected for the specific course-related subject,
Yeah.
correct? But if the student is having the fellowship, that is just an extra degree with that, and that candidate can be chosen for any post, lecturer post, or consultant post, or the junior consultant post in the corporate hospital. So that is going to be advantageous, but they have the limitation. Candidate will only say, I don't want to work. If the cardiac fellowship he has done, he will say, no, I will do only cardiac cases. I know so many students, they are just saying, I have done pediatric fellowship, I will do only pediatric cases, I will not do the
Oh,
cardiac. So when I say, okay, fine, you do the pediatric cardiac case, no madam, I have done only pediatric fellowship, so I can't do it pediatric cardiac. Pediatric cardiac fellowship candidate has to be selected for that case, that post. So there are, that many problems we are also facing as a high candidate selection for the posts are concerned. And I don't know what is happening to the pain, because pain is having the limited number of the seats at the limited consultant post. So if the 10 candidate will come, how can you take all the 10 candidates? You cannot take. You can take only one. And the department is having only the criteria for keeping the three posts. One is professor, one is associate professor, and one is assistant professor. So three people are already there. So then the time gap is there and the number of candidates are limited. This is what I feel for. This is the limitation of these courses.
Yeah, so actually, Mukul sir, madam brought a very important point. Is pediatric and pediatric cardiac different? Like sometimes they say, no, I will not do pediatric cardiac. So how to go about it? You teach everything under one roof, right?
Yes, madam. Actually, we are the dedicated pediatric anesthetist only, and our institute have all pediatric surgical branches like cardiac, orthopedic, ENT, ophthalmics, pediatric surgery, and our fellow and FNB student have to work in all field.
Even the cardiac one, right?
Even the cardiac.
They must be going in rotation, correct?
Yes.
For the cardiac postings.
In pediatric only.
In pediatric cardiac.
Only in pediatric cardiac.
So when the question is coming for the pediatric cardiac interventional procedures, then they refuse to go.
Actually, presently we have only pediatric cardiac surgery department, and the interventional cardiology is under the development, and this will also be managed by our department only, and our student will have go to
Pediatric surgery department, pediatric anesthesia department.
Pediatric anesthesia department.
Okay.
Natarajan sir, I think luckily the cardiac fellows take job as a cardiac anesthesiologist only. So the corporates are looking for them. So there's no option.
The thing is that, for example, when I am interviewing a candidate for the job, I am looking at two things. One is whether they have an extra qualification. Second thing is from where they're trained.
Okay.
Because a guy might have done only a 1 year PDCC, but he might have come from the high volume centers. Then he will be more experienced than a guy who has done a FNB or even a DM or a DRNB from a low volume center. Because not all the centers are having an equal distribution of the cases. You might be knowing that some of the centers are 100 for 99% in op caps, only the CABGs. Some of the centers will have some CABGs with a valves, and only the few centers will have some sort of pediatric or a vascular and thoracic together. So definitely I'll prefer a guy who is having some qualification, but not only the qualification, I will look into the centers from where he is trained. Because the administration doesn't mind whom you are hiring. It is the interview person is going to be the HOD of the department. So definitely, definitely you are going to prefer a guy from high volume centers who had done some sort of fellowship or PDCC, even a DRNB.
Okay, that's great.
Yeah.
So that remains with you whom to hire. And okay, when these candidates, after taking fellowships or the Fellowship of National Board or the DNB, when they go out in private practice or in corporate hospitals after their fellowships, so do they face these problems? Like, has anyone told to you, now I'm not, like for a pediatric anesthesiologist, suppose, as you said, in your area, so much awareness is not there, Mukul sir, to call a pediatric anesthetist. But a fellow has learned from you and now he's doing his private practice. So is it that he faces that he's not called for routine cases? अरे ये सिर्फ बच्चों का जानता है या छोटे बच्चों का ही करता है?
See, it will happen. Okay. Definitely when you start working in an institute after coming from a fellowship, it's not only anesthetist. Any fellowship, it may be a cardiologist, it may be an ortho, it may be anybody who is coming after the fellowship in a young age. Definitely there will be some hesitation or some not so preference over a senior person who is experienced. It is bound to happen, but when you have the patience and persistence, definitely you will show your mettle, and slowly people will start understanding your ability, and then people will start calling you. Because I know from my own experience from the cardiac how the over a period of time, I think Madam Manjula Madam might be knowing how the cardiac surgeon used to be dominant in those days. Okay, now the cardiac surgeon listen to you because they understand that you can make a difference. So, for example, if somebody is asking me to give a blog, if I have somebody who is experienced in the blog, whether the junior or the senior, it's my mentality to accept that. I will tell him that, okay, come on, you know, give the blog. So you have to wait for an opportunity, prove yourself, and then you will slowly come up the ladder rather than thinking that I have a qualification, nobody is calling me.
Okay,
So
okay.
it will take time for you to reach that ladder. Yeah.
Gargi madam, regarding the pain fellows, after pain fellowship, in our area, we have all type, we have some consultants who continue practicing only pain. We have some consultants, they do routine anesthesia as well as pain clinics. So what would you suggest? Should they do dedicated pain cases? Should, and it takes a lot of monitorial this also, when they have to start their own pain clinic, they should have an CT guided procedure if they want. Then they should have a separate lab, then a CT machine. So, what would you suggest these pain fellows do? Routine cases as well as do pain practice?
No, actually, I prefer my fellow will do the only dedicated pain practice. It will take time, but ultimately they will succeed. Okay, and if they I am only doing the pain, not now I am not doing any anesthesia cases, but it will take time like any other private practice like medicine and pediatrics, like think it will take time to develop your own practice, your own patient pool, but ultimately you can do. And those
So
fellows
maybe
who
they
are
should
doing
start
the,
from OPD so that they get patients.
yes, you have they have to do the OPDs, they have to go to the uh, uh, outskirts also to see the patient, because pain is everywhere, so there is nothing, the cases are there is a lot of cases all over the everywhere actually. So I think for the pain it is better to stick for the pain practice only, but there is also a monetary problem what you just told that, uh, but I think it will dilute your pain practice if you do. And what I my observation is that what doing the anesthesia and pain practice simultaneously, then sometime after some days they actually feel a little bit frustration in the pain practice, because there is less money, and in the anesthesia they can practice
Easy
more,
money is there.
free money, like that. So I always tell my fellows that please stick to the pain only. It will take time, but
Okay.
ultimately you can uh, get.
But
Yeah,
I
yeah.
think if you want to see the practical point, in
Yes.
the beginning to establish the pain practice, it takes time. And for survival, they have to do something, right? So usually people do the general anesthesia also.
Yes.
And as you said, in the future, after some time, if they start getting frustrated, then they want to do the combined practice, pain practice and both. So they want to take the advantage, and there is no harm, I think there is no harm if person wants to do in private both the practice together. But if you are attached to the institution, or that corporate sector which they have the separate good established practice, then they should continue with the pain practice only.
Dr. Manju, I want to make a point
Yeah,
that Dr. Mukul Kumar's and Dr. Natarajan centers, like, they're talking only about cardiac, pediatric, and Madam is Gargi, Madam is talking only about pain, and pain fellows doing only pain, cardiac fellows doing only cardiac, pediatric doing, that's the most ideal thing to do. Yes, they are super specialized, they have more expertise, they have advanced knowledge in echoes, everything is true. But look at the reality in Mumbai city. I am 35 years anesthetist here. We have students passing out, 40 students pass every year. Okay, they do
correct.
different fellowships. And when they are in trouble means the job market I'm talking about in a city like Bombay, they come back to us only. And what they will say, Madam, मैंने cardiac किया है, but the job offered is if I do general anesthesia, I get a better pay. So I want to do general anesthesia. They come back to us to ask us a few questions about general anesthesia. So I have seen cardiac fellows do, forget pain doing anesthesia. I have seen cardiac fellows do general anesthesia. I have seen pediatric anesthetists do obstetrics. I'm telling the truth. This is what happens in Mumbai city.
No,
While
no,
I
this is true.
talking
This is true.
all ideal
Absolutely.
stuff you are talking is it's very nice to talk like this. As a teacher, even I would like to talk like that. But I am bringing out points which are practically happening. When I talked about the MD people are lacking today, it is not because I don't believe super speciality should not be super speciality is a must today. And most of us, see, if you see, India is following the West only, whether it's these fellowship programs, whether you look at the history of anesthesia and you look in the initial stages, when the anesthetist did everything, then came a time when we started doing a few things, then again we start doing everything. These cycles go on, and lots of it is based upon the job market. Finally, everybody has to survive in the market. They have to, by that time they are married, they have children, they have to take care. They'll say, Madam, सिर्फ कार्डियक किया तो पैसा ही नहीं मिल रहा है, क्या करूं मैं? I
No,
say
it's very true.
Yeah,
ideally,
in our area
this
also
is a
we have a
fact. This is a
cardiac
fact
This
that
anesthetist
is
who
this
cardiac,
gives
is
regional
cardiac
blocks
DM,
also.
DM in cardiac anesthesia goes under general anesthesia. DM
correct.
in pediatric anesthesia. From my own institute, I've gone and done obstetric anesthesia. These are the facts in Mumbai city, at least, because they all come back to me and ask, Madam,
So,
what do we do?
so that's why we
These
are
are
asking
facts.
now,
So
what are the job
that is
opportunities?
why we are saying that keep your options broad and open. Yes, do super specialities, do learn more and more, be prepared for the for this competitive.
Practical
This is going to
facts.
be, it's going getting more and more competitive for everybody. It's getting more and more stressful also for everybody. But sometimes you need to keep options open because finally we need to survive. And we have to have we have to do our work also. We have to look at the monetary side also. We have to see the job opportunities. There are so many things we have to put together. So we are in a transition phase, I would say. Right now, we are in a transition phase. It's slowly changing. Yes, certain areas like South, especially, I know cardiac means they will do only cardiac and pediatric or some centers. But Mumbai city, like half of the cardiac anesthetists are just MD, and only few are. How many DMs are we producing per year? Just how many? Two, no?
In as you said rightly, in
Actually,
Mumbai city,
This is the
ac-
fact of life.
actually, there is three type of practice. One is government setup based practice, and second is corporate sector, and third is freelancing practice. If anyone want to survive in freelancing, he or she should leave the super specialty uh,
See,
Go
tamga.
the general practice.
coming to the
Yeah.
point. Yeah, that is it. Yeah, that is the
and
point.
In government or in corporate, he or she may get the advantage of these super specialty courses, but in freelancer it is.
So that is what I said, na, ki if you want to do the DM, then you stick to the good institutional
Yes,
high
Yeah, yeah.
positions. You will
yes.
be more
Yes,
matlab,
the
fit
super
person for that.
specialty does give you higher positions. It does give you global recognition. It does make you a better anesthetist. I agree to everything. And I am for super specialty, but we should know what's going on in our own cities and what the juniors are facing because they come to us to ask for solutions and we should know what others are doing and what we can advise them.
So that is why
Be-
this webinar has been kept to just, give them the good right direction. So basically the super specialty fellowship courses or DM courses are just an additional degree for them, but practicality in the life is entirely different. And we have to decide as per the present scenario and as per the need of the city where you want to practice. So I think we should move for the next question, Shilpa.
I
Yeah,
agree.
that's it.
Yeah.
Only
Yeah.
small one comment about
Correct.
this. Okay. I agree that the super specialty have a limitations, but I can talk about the cardiac. Now look at the new emergence in every field. Okay, your interventional procedures are increasing. The surgical advancement in every field is increasing. So there is a non-operating room anesthesia, NORA.
Yes.
It's coming in a big way. So we cannot just say that super specialty is having its own limitation to a particular field. It is going to be the future.
Yes,
So
it is
Yeah.
going to
if
future.
we
Yes, we agree with
so
you, but we are
we
dealing
have
with all other points
no,
also.
if we cannot, we have like, I cannot tell my student that stick to only cardiac anesthesia. I have to tell that non-operating room cardiac anesthesia. Now it is a NORA become a NORCA, because you have a lot of interventional procedure, electrophysiological procedures, and the percutaneous interventions in a huge way. So everything is coming in a big way. So I agree that when you work in a system, sometimes even the super specialty has to do a general cases, but we have to train our people to get into this field. That's
Yes.
what.
Now, many questions are coming from the audience side also, so I would request all the panelists
Yeah,
to.
we
Yeah,
may,
one
sir,
thing I
you
want to
may start
answer.
NORA, DM in NORA now soon. I will
Yeah.
not be surprised if you start a
So
DM
one question
NORA.
I want to answer that Dr. Satish, somebody asked that now what about the trauma specialist and the transplant anesthesia and critical care medicine? Yes, this also another specialty, because as we talked about that when you do some particular case for a quite long time, it can be a transplant, it can be a trauma, it can be a critical care, you are going to be expert in that area. So if somebody is, some anesthetists are having that attitude to work in a critical care, then the DM critical care is a good choice, because I cannot imagine myself working in ICU, because basically I am a cardiac anesthetist and I love to work in only operating environment.
So at your age and at your, that status, you can say this, but the person who is just going to begin the career, the difficulties and the, scenarios are different. So we have to consider that also.
That is not bad.
Yes,
There are
critical
a lot
care
of no. Now the anesthetists are having a wide opportunity. That's what I am trying to tell you, that because every area, including the ICU, transplant, and the trauma and the emergency medicine department, the anesthetists are having an excellent opportunity work if are having the right attitude to work in that area.
So is
So-
it time that we start this transplant anesthesia after the MBA internship, instead of doing 3 years of this and then going to transplant? Maybe these courses also will come. Transplant anesthesia after your internship. Cardiac
Yeah,
anesthesia
but
after
it
internship.
is.
Why you want to do general anesthesia and then go into cardiac? Which
There are 2-year course there where post MBBS transplant anesthesia it is there, but
it should come. Yeah, it should be there. Yeah.
Acha, it is already there.
yeah, it is
I
there.
was not aware.
Yeah, it is there. Some of the private institute offer you transplant anesthesia after your MBBS for a 2-year course, but it is not equivalent to your MD anesthesia, or it is not equivalent to your post MD transplant anesthesia.
Yeah, but
These courses have to be
Deepa
accepted
madam,
by the
I would.
university. The university has to start accepting all this course. We have to put forth all these ideas also. The transplant anesthesia, 3 years after internship. Cardiac anesthesia, 5 years after internship. Because cardiac anesthesia is not only operation theater, it is the critical cardiac ICU also, where they have to take care of the ICUs also. So maybe they'll need 5 years. So something like that. So why do they go through, why have they to do hernias then? If they're going to do the only cardiac, let them do right from the beginning. They'll be, what I mean to say, at a younger age, let them become experts in cardiac. Why they have to become experts at the age of 35, 37? Let them become by 27, 28 experts in cardiac, or let them become experts in transplant anesthesia by the age of 27. They'll settle faster in life.
I might differ in this. I feel, they should
I
have
think,
the...
Shilpa, we have to take the questions
Yes,
from the
yes,
audience
questions.
now,
Yes, yes,
because
yes.
otherwise this topic is very hot discussions. So the first
Yeah, so
question,
one was
Doctor, you
Satish
can
sir
see the
is asking.
questions?
Yeah.
Okay,
So
so
cardiac
just,
transplant, as same what we discussed, is
yeah.
supervised by transplant anesthesia. Cardiac transplants are supervised, Natarajan sir. Are they supervised by transplant anesthesia or the cardiac team
See,
at your place?
the only hitch in the transplant anesthesia is all the transplant comes under the transplant anesthesia except heart and lung.
Mhm.
Basically, when you go to a transplant center, so we call it as a solid organ transplant. So usually heart and lung transplant comes with the transplant team of the cardiac anesthetist and cardiac surgeon.
Okay.
Otherwise, you have a institute
Yes,
of,
yes.
I think Delhi is having an institute of transplant anesthesia fellowship. Yeah.
Okay. So, since we had to take only 4 specialties today, actually we haven't covered onco anesthesia, trauma anesthesia, transplant anesthesia, and trauma and onco are also coming in a big way. Does anyone
And
want
there
to
is
say?
one more question, that who are accredited to train these super specialty candidates? Many of the faculties earlier decades did not had the super specialty degree. So I think NMC has already given the guidelines for that after 2000 onward, the faculty has to be a degree holder. Correct? If I am not mistaken, Dr. Natarajan.
Actually, it is, if I remember correctly, after 2024, if you are applying for a specialty DM or a DRNB,
Sir,
only,
faculty.
yeah, that is what, the faculty has to be qualified.
Faculty
Okay.
should have the degree.
Yes,
Actually,
yes,
it will
yes.
depend on the start of that particular branch by NMC.
Exactly. Yeah. Because, for example, if you are
some
having,
branch started at this time, it will give 10 years for the transition phase.
for example, if you are having an institute which is already having a PDCC, then FNB, then DRNB, then whoever the existing faculty who are having an 8-year experience will be a faculty. But if you are starting a new course, then you should have a qualified faculty. That is the criteria.
That is the criteria, correct.
Yeah.
Oh.
Yeah.
And Dr. Gargi, somebody wants to know this FIPP in
FIPP.
Kane. Yeah.
Yes, it
So
is
from where it can be done?
it is actually conducted by the World Institute of Pain, WIP, and it is just an exam only.
Only exam. So
Only
online
exam.
exam.
No, it is a offline exam. You have to do the procedure over the cadaver, and there are some OSCE type of questions, some interviews like that, and you have
So
to
they
just
have
pass
particular
the exam.
pattern. They have the particular
Yes,
pattern to give the
yes,
exam, and they have the
yes,
particular syllabus for that, correct?
yes.
Okay.
So it is
So-
just an exam.
So Shilpa, now you can ask all the panelists to give one positive
Yes,
comment
take home
regarding
message.
this courses and all, and then you can
Yes.
conclude.
Yes, Deepa madam, what you have to say for the postgraduate students who are freshly passed MD, DNB, what to do?
MD, DNB. See, when we were kids, we were told 10th standard pass ho gaya, then you do very well in 10th, life is easy. Then today we had a inauguration and one of the AMC said, and it's true for all of us. When we were in the 10th, when we were school, 10th May, if you do well, your life is made. Then in the 12th, by the time you pass 12th, the 12th May, you do well, your life is made. Then you get a medical seat, your life is made. Abhi MBBS ho gaya, then they say, so speciality to chahiye. See, my time speciality, okay, life is made. But now it doesn't end there. It has, and all our students know it doesn't end there. They have to do something more. So either a fellowship or a super speciality. I feel sorry for them that their work means it's a never ending course, and that is why I feel all these super speciality and all should be encouraged. But they should be soon after internship, I feel, so that they are more established and stabilized at a younger age. That's all I feel. Because let them live a better life at a younger age. Because doctors slog too much and they start earning too late. That is what I feel.
Mukul sir, what is your take? What is take-home message? What you would like to give?
Actually, pediatric anesthesia is in developing phase, and I think the the MD student should go for the training of pediatric anesthesia for the better management of pediatric and neonatal cases, because it is about 40% caseload of the all total surgical cases for the anesthetist, and usually it is not properly managed, particularly neonates in our field. So I request all the PG students or MD pass out that they should be trained in the pediatric as well as neonatal anesthesia.
Okay, thank you, sir. Natarajan sir.
For me, only two things. It depends on your passion. Because when actually I got this cardiac anesthesia name into in 1996 from one of my senior. Now he is in Ahmedabad, Dr. Naman Sastri. That was the first like eye opening. Oh, there is something called super speciality after MD. The same thing I used to tell all the MD that it's a passion. After MD, what you want to do? Whether you want to have, because I have a high regard for, because I cannot I cannot easily manage a cardiac patient for a non-cardiac than a cardiac patient coming for a cardiac, including a neonate. I'm sure about that. So we have to have a passion for that. What we want to do, whether you want to become a specialist or a specialist training doing a general anesthesia, because the specialty is going to improve your competency level in a different level. You may not do the same, like if you do a cardiac, you can do a obstetrics, you can do a non-cardiac, you don't have a pediatric, anything you can do. But specialty is always coning your skill actually. That's what I always feel. It may not pay the way you want, but definitely it's going to give you a satisfaction in your level, where whatever the case you are doing. That's
I'm fully agreeing with Dr. Natarajan that competency level definitely increases after doing the super specialty courses. Somebody has asked regarding neuroanesthesia also. So Dr. Kamath, he wants to know that from where the neuroanesthesia DM can be done and what are the opportunities. So
I think most of the institute are having a DRM neuroanesthesia, and Bangalore Nimgans is having one of the best training for neuro, and even I think Sri Chitra Institute
Shri
in
Chitra is also having, Bangalore is
India
also,
Hospital,
Nimgans is
Mumbai.
having, then AIMS Delhi is also having. So there are many centers they are doing the neuroanesthesia DM.
I think Mumbai Joseph sir is doing.
Yeah. India Hospital.
Yeah. Dr. Nandi,
Nandi
Shilpa.
madam, what is your take-home message?
If you are passionate about the pain medicine, you have to stick to you have to invest your time for your independent practice. It will take time, like cardiologist, like pediatrician, like that. But you have to stick to your to develop your own practice. It is a totally independent field, and it is truly rewarding. And for the monetary point of view, if you can do the vertebroplasty, kyphoplasty, spinal cord stimulator, you are the you will be paid like any other neurosurgeon actually. Huh? And it is under the insurance, and everything is coming under the insurance. So it is not like that you cannot uh, get money from this field. Huh?
So
It is,
financially, you are going to be very well if you
yes,
do
yes,
and
yes.
stick to
And
this procedure.
it is independent field. And you can develop your own practice. So
Okay,
it
thank you,
is,
Dr. Nandi. So Shilpa,
So,
final comment.
somebody was asking DM Onco Anesthesia. It's available at Tata Hospital, Mumbai. There
Yes.
are more centers, but I know of Tata.
Even
Yeah.
it is there in Ahmedabad.
and AIMS Delhi also there.
AIMS Delhi also, yeah, they have, yeah.
So we are coming to the end of it. Thank you, ICA. Thank you, Manjula madam, for this opportunity. And thank you all the esteemed panelists for taking this topic, which is the hot topic. Even my students, they ask me, Madam, iske baad kya karu main? So we really want to know what the PGs want. They want to know what super specialties they can take in. And thank you, Nandi madam, Kane madam, and Mukul sir and Natarajan sir. Thank you for your esteemed, valuable time and sparing your knowledge and giving advice to the PGs. Thank you so much.
Thank you. Thank you so much.
Thank you.
Thank you.
Yeah. Thank you,
Dr.
thank you.
Bimla or Vinit?
Thank you, ma'am.
Thank you very much.
Yeah.
Thank you
So
very
we
much.
can
Thank you, Dr.
conclude.
Manjula,
Yeah.
Dr. Shilpa. Yes, and for a very comprehensive, in-depth, discussion on the subject, and I'm sure the all the participants, especially the students, must have benefited a lot. And with that, we conclude the session. And good night. Thank you.
Yeah,
Good
thank
night.
you so much.
Thank you, sir.
Thanks. Yeah.
Thank you, Mukul sir, Natarajan
Clarinet
sir, and Nandi.
person, Shilpa.
Yes, ma'am.
Yes.
Thank you so much,
Deepa madam, thank
everyone,
you.
for joining this session. Clarinet is really glad to have all these brilliant people together. So, with all your permission, I'm closing the session for today and looking forward to hosting you again. Thank you so
It will
much,
be
everyone.
uploaded, right?
Yes, ma'am.
Yeah, thank you so much.
I'll send the links, ma'am.
Yeah,
It
thank
takes
you,
1 week.
everybody.
Bye-bye.
Bye, sir. Thank you so much. Bye. Thank you, everybody.